hospital in the Pulvertaft hand unit. It's an orthoplastics unit, so we get to see a wide range of injuries. And I think hand surgery is the beauty of hand surgery. It covers multiple specialties. It covers plastic surgery, orthopedic surgery, and then you also interact quite commonly with specialties such as neurophysiology, the emergency department, rheumatology, and so on and so forth. So the two topics I'm going to really be touching upon today are infections, which I think are really important things to get your head around and what to do with them. And then I'm also going to do a bit of a whistle-stop tour through elective hand surgery, which is a huge topic, but definitely rewarding and interesting in its own right. So in terms of hand infections, what I'm going to cover is bites, so human bites, dog bites, cat bites. We're going to look at some pulp and fingertip infections, and then we're going to go on to the flexor sheath and other deep space infections that you might see. So why do we worry about infections in the hand? So the hand's an extremely complex organ containing kind of tendons, ligaments, and highly specialized structures such as a pulley system, which are all very sensitive to injury and also very sensitive to infection. What happens is a sequelae of that is that you develop swelling. Swelling then turns into fibrous tissue, and then the fibrous tissue then causes stiffness and loss of power. An infection which goes untreated can cause significant skin loss, and then go down, cause necrosis into muscle and tendon structures. It can also damage nerves, which can give people complex regional pain syndrome. And then as a later consequence, with insufficiently treated infections or ones that go missed, they can develop osteomyelitis as well, which can be very challenging to treat. And there are some infections which you should be aware of and can progress on to systemic conditions such as toxic shock syndrome and systemic infections such as necrotizing fasciitis. It can be life-threatening. So when you see a hand like this one in this picture, you should be really worried and really be acting upon it promptly and calling your seniors and consultants and letting them know about it, because this is technically an emergency. So human bites are actually very common injuries, and you can see I've got a couple of pictures of some famous biters in sporting scenarios, but they do happen often. It can be little kids biting each other. It can also be part of non-accidental injuries. So you need to be really aware when you see someone with a bite, that the importance of taking a thorough history and understanding the consequences behind that. And the thing with human bites is that they've got some really horrible organisms which can cause quite nasty infections. So there are things like strep viridans and Staph aureus, which are kind of commensals, but that also live within the mouth. And there are specific organisms that we see in humans, such as Eikenella, which you might get asked in some sort of MCQs. So you need to be aware of that. So bites are quite nasty injuries, especially human bites. The one thing you might see quite commonly in a Saturday morning, usually, or a Sunday morning, is a so-called fight bite. So it's quite a specific injury, and you kind of need to know the kind of mechanism, how it works, and how that injury can cause joint infections. So what normally happens is that they present generally a few days later, actually later in the week, with swelling of the metacarpophalangeal joint. And what happens is they get a puncture wound as they clench their fist, and the person's tooth then goes through the skin and goes through the extensor tendon into the joint and inoculates the joint. And that generally takes a couple of days for that to brew an infection. And what happens is that when you straighten the hand, all those layers where the tooth is penetrated to then overlap, so you can't see a clear channel. So when they present to you with a flat hand, you often look at the skin and think, oh, actually that's a superficial graze. There's nothing to see here. It'll be fine. I'll give some antibiotics. But actually, what you need to do is recreate the actual punch injury, and then you'll see that actually that tooth has gone pretty far into the tissue and probably gone through all those layers deep into the joint. In these sorts of scenarios, it's important to take an X-ray, because you might see that there might be a piece of a foreign body or a retained fragment of tooth within the joint. You may also have fractures associated with this injury as well. So this is something that is quite a common injury, and you need to be aware of it. If you do see it, you do need to treat it quite aggressively. This sort of injury requires washout in theatre, and often the extensor tendon is actually injured at the same time. And generally the teaching is that you don't repair structures where there's within the context of an infection. So if you do see an extensor tendon, and it's super tempting to put a few Prolene sutures in there, but really do try and avoid that, because that'll be another nidus of infection which continue that. And also understand that this sort of injury requires assistance from your microbiologist, and need admission for that, and also may require multiple visits to theatre so you can wash the joint out properly. So that's one that you will see quite often. Then we go to cat and dog bites. They're also quite interesting injuries, and they have specific organisms related to them, but they also don't forget about your common staphs and streps, which of course be present as well. And really, if you can see the pictures here, that the cat teeth and the dog teeth are quite different entities. You can see with the cat tooth, it's actually quite sharp. It's almost like a hypodermic needle. So they generally go very deep down. So you might think it's a graze, but actually it's probably definitely gone out into flexor sheaths and down into bone. And they have specific organisms such as Pasteurella, and also something called cat scratch disease, which is a bacillary angiomatosis. So in contrast to that, the dog teeth, they're quite blunt, and they can also kind of maul people. So they can also not only do they bite, but they also tear tissue. So the zone of injury that you might get with a dog bite can be quite broad. And they also have their own specific organisms such as Pasteurella and Bacteroides, which you'll be able to culture on your swab results. And you can see up here on the top left picture, it's quite a nasty injury. This person's been mauled by a dog. You can see there's also skin loss. There's probably muscle damage. There's probably tendon avulsions as well. You can see the zone of injury is quite broad. It's also important to take an X-ray, because you can see on the right side that you've got fragments of bone which have been punched in by the force of the dog's bite, and that tells you that the injury is quite severe and probably will require formal debridement and washing theatres, because the risk of osteomyelitis in these injuries is quite high. And then you can also see in the bottom left picture that actually something looks quite clean day one or day two. A few days later can definitely progress significantly and cause swelling and pus formation. So it's something that when you see in the emergency department, it's not something that you should take quite seriously and actually consider admitting these people for IV antibiotic elevation and potential debridement of these injuries. So this slide is actually probably the most important of all my talks in terms of infections. There's certain things you should definitely do. So number one, taking an X-ray, assessment of the neurovascular status of the hand, identifying which structures are involved, marking the cellulitis or the erythema with a marker pen. And also I actually quite like dating it, so you can see what happens over the next few days as you treat it, or whether it progresses beyond those lines, because you may need to change your treatment tact. IV antibiotics, I think, is an absolute must in these sorts of injuries. That will get on top of the infection systemically. You also need to involve your therapist. So that's what the goniometer is there for. You need to involve your therapist because, as I said, the stiffness can be a significant problem with these patients. So getting them seen by your hand therapist is absolutely essential. And I think that's relevant to all of hand surgery, to try and get your patients moving as soon as possible, as Dan highlighted in his talk. I think elevation is also extremely important. On the right side of this slide is a Bradford sling. It's an extremely useful thing to give to patients, and I think it's absolutely mandatory that if somebody comes with a hand infection or a cellulitis, that they should be elevated in this, and it should be just above heart level, so it allows drainage of the fluid. And I think surgery also has a role in these infections to debride those wound edges with it, and also drain any abscess that may be formed. So it's these collection of treatments that are really important in dealing with someone with a hand infection related to a dog bite or any other injury. These things you definitely need to do as an ST3 registrar. So then we move on to finger infections. So you'll see a lot of these infections in your clinic and in your trauma clinic. Essentially, they're called paronychia, which is an infection of the eponychium of the finger. You see this kind of classic appearance where it's normally on one side of the finger. You get swelling and sometimes a collection of pus, and it's really related to the anatomy of the nail plate and also the nail fold. So you've got, in terms of your nail anatomy, you've got your nail plate, which is the keratin structure, which is the actual formal thing that you see on the outside of the finger. You've got the germinal matrix, which sits underneath the nail fold, which is where the nail grows from. You've got the distal phalanx bone, which supports that structure, and then you've got the sterile matrix and the hyponychium, which sits underneath the nail plate itself. So here, the infection gets in. Sometimes you get people who have who are nail biters, classically get this sort of injury. Sometimes gardeners get this sort of problem as well, and it's quite a painful and sore situation. In the early part of this infection, it's probably adequate to give them some antibiotics to treat it. Sometimes people say soaking the digit that's involved. Of warm soaks can allow the infection to settle. But in this sort of scenario where you've got a formal abscess, I think it requires incision and drainage. And there's multiple different incisions that you can do, but you want to be careful that you don't damage the germinal matrix underlying this. You can cause abnormal nail growth and potential inoculation deeper down into the structure. So be careful and plan your incisions appropriately for this sort of problem. They require quite close follow-up in clinic, so you can send them home, take some pus swabs, and make sure you see them in a couple of days' time just to make sure the infection's settling as well. So it's a very, very common thing that you'll see in your clinic. On the opposite side of the finger, you'll see a collection of patients. Usually they're kind of middle-aged people who are keen gardeners, and they've had some sort of inoculation incident to the pulp of the finger, and they present in quite a lot of discomfort. They get throbbing, rapid onset pain and swelling. You may see a collection or pus formation under the pulp, and the reason why they're so painful is that in your pulp you've got this very tight, highly specialized structures and fascial structures and fibrous septa which connect the bone to your pulp, and that stabilizes it so you can pinch, grip nicely. And what happens here is that pus gets within those compartments, and it creates almost a very localized compartment syndrome. So they're very uncomfortable. They get throbbing pain. They can't seem to relieve it even with elevation. And it's really because those fibrous septa are packed full of pus and they're causing significant pain. So these, once again, quite common infections, and you really need to act upon them quite quickly. If you do get a situation where it's quite, the abscess is pointing and it requires drainage, then what you need to do is really break down those septa and release those. And there are various incisions described, but the preferred technique is a mid-lateral approach where you go just to the side of the finger and go just down into the septa and break them down with your scissors. Then you realize that each septa you get more and more pus coming out of it. And generally within the context of infection, it's not good to suture the wounds up and like that. Just leave them open, and once again require regular dressings and antibiotics to treat that. So that's quite a common injury. In terms of planning your incisions, it's important to know where you're making your incisions. In terms of your hand, your thumb is absolutely crucial. So you need to avoid the side that pinches onto the index finger if you can. So go for the radial border. In terms of your index finger, if you can use the ulnar border, which is away from the side that you pinch, is also a good idea. And then in terms of your little finger, try and make your incision on the radial border, as that will avoid any sensitivity on the outside of the hand, which is very, very important. So just think before you rush to theatre that where am I placing my incisions, and actually can I put them in a slightly more appropriate position so they don't cause a problem. So that's Phelons. Flexor sheath. So Flexor sheath is also something that really not to miss in the emergency department. So the Flexor sheath is a beautiful structure. It's high specialized pulley system, and you've got these specific annular and cruciate pulleys that allow your flexor tendons, your FDS and your FDP, to glide beautifully within the fingers. And you can see that your crucial pulleys that you need to be aware of are A2 and A4, and so you really want to try and preserve these. And in terms of your flexor tendons, they have a specific blood supply, and supplied with a vincula. So there's really not much room in the flexor sheath, and that's how flexor sheath infections present themselves. They a very tight compartment, and there's no room for really any pus or anything like that else in there. So these could be quite quite painful injuries. And what you'll see is this classic picture where you've got a very swollen finger and canavel describe 4 cardinal signs. So the most important earlier sign is actually pain on passive extension. So you gently bend their finger, try and extend their finger, and they'll complain of a lot of pain. They'll have it in a flexed posture and also be extremely swollen and painful as well. There's also percussion tenderness on sheath. So when you palpate across it, it will transmit pain up their arm. And when you've got 4 of these signs, you've got to really be worried that the patient's got a flexor sheath infection, and you need to do something about it. And generally, these are the described techniques. So these are 2 images of a patient's hand. You can see that on the left side, what they've done is used cannula, and they've done 2 approaches. So these zigzag approaches are called Brunner's incisions, and they're quite the classic approaches to get to the flexor sheath and flexor structures and neurovascular bundles. So what they've done here is that they've done an incision in the palm, just at the A1 pulley. So that's your first pulley, and that gives you the entrance to the flexor sheath. And then I've also done that one at the fingertip as well, another V-shaped incision. And what they've done is that they've passed a cannula, or actually in my practice, I use a pediatric feeding tube to enter the A1 pulley and then transmit it all the way up the sheath, and then irrigate the whole of the pulley with copious amounts of saline, and then that washes the pus out of that joint, washes the pus out of the sheath. And that's something that is actually an emergency. So if you do see something like this, it's something that you should be considering speaking to your seniors about and getting to theatre. And the crucial part of that is that if you don't do that, you can destroy the flexor sheath, so that highly specialized structure can be damaged and fibrose. You can cause tendon rupture, which is then a challenging reconstruction. There's lots of papers written about whether you should leave these tubes in and irrigate them on the ward. There's quite a few studies that have shown that actually that makes no difference. So multiple visits to theatres is actually probably the way to go. You can leave these wounds open and allow any further pus to drain. Once again, it goes back to my original slide of elevation, antibiotics, hand therapy for management of these infections. And then we go into the kind of last section of infections in the hand. These are the deep spaces of the palm. So you've got a number of compartments within the hand, which then interconnect, which can then cause specific presentations of abscess formation. So you've got your thenar space, which sits just under this kind of bulky muscle under your thumb. You've got your mid-palmar space, which is in the middle, and then you've got your flexor sheath, which then interconnect to those compartments. And these can be quite misleading. They can give you false positive canaval signs. So you think they've actually got flexor sheath infection, but they really don't. And sometimes you go ahead and explore the flexor sheath and there's no pus there. So it makes you think, really, actually, where is the pus? But clearly this patient's got infection somewhere, but what is it? So you need to start thinking about these other deep spaces, and they're quite difficult to diagnose. And then there's also interconnection between these spaces, which can cause specific types of abscess, which I'll touch upon in a second. So one of these specific conditions is called a horseshoe abscess. You can see this lady, she's got, in this picture, she's got swelling of the thumb and into the thenar eminences, and then she's also got swelling of the little finger. And there are some situations where there's an interconnection between the flexor sheath of the little finger and then also the sheath of the FPL, and these then connect within the distal wrist, within the distal forearm in a space called Perona space, and this can cause a kind of U-shaped or horseshoe-shaped abscess. So this requires kind of multiple approaches to drain those abscesses and make sure there's no foci of pus left over. So if you see something like this, it's quite an interesting presentation of a deep space infection. Collar button abscesses, they're also relatively common abscess formation. The people I've seen, the kind of people that you see with this are once again gardeners or people that lift a lot of weights, where they've got calluses just between their web spaces and their metacarpal heads. They get an inoculation between the web spaces, and then you can see on the bottom image they get an abscess formation. And there's nowhere for the pus to go because it's quite a tight compartment, and then it kind of presents and goes back towards the dorsum of the hand, and has collects at the back of the hand. So what you really need to do here is drain both sides of the abscess to try and get to all of the different spaces. So that's quite a nasty and specific injury that specific infection that you can get. So that's really an overview of elective hand surgery. Sorry, of infections. I'm going to move on to elective hand surgery, which is a really interesting topic and quite a diverse topic as well. I wanted to break it down into how people will present to your clinic. So they'll probably present with odd bendy fingers or lumps and bumps or wrist pain or specific conditions as I've kind of outlined here. So this is really a touch upon what you might see in a day one clinic as an ST3 registrar. And the aim of this next section is really not to go into too much detail, but to give you a flavour of what kind of conditions you might see and how you might manage them. So you come to clinic and you're the day one registrar and you're working for Mr. Williams, lucky you, and you get a child coming into clinic and they've got a bendy little finger. So and when you talk to them and take a history, they've got no history of trauma. It's not painful. So I wanted to kind of get your thoughts about what you think this sort of deformity might be. Is it normal, or is it one of these funny situations? So give you a few seconds to go into that, and let me know what you think. Brilliant, yeah, great, yeah, clinodactyly, exactly. So you might see quite a few kids in your kind of elective practice, and they'll have all sorts of bendy fingers and flexible fingers and curved fingers and things like that. And you also need to try and identify and pick out the ones which you need to act upon. So this is clinodactyly, so it's an angulation of the little finger, and it kind of bends in usually the middle phalanx. It's got a few important associations. So it's associated with Down syndrome, and it's not. It's actually a reasonable thing to do is to take an X-ray of it. And when you do take an X-ray, you might get this specific thing called a delta phalanx, which is type 4 clinodactyly. And here, what happens is that you've got an epiphysis, a physis, which then connects the distalmost aspect of the middle phalanx to the proximalmost aspect of the middle phalanx, and creates this U-shaped middle phalanx, which then abnormally grows inward. So with this sort of injury, this sort of condition, it's usually observation and reassurance. However, if it becomes quite intrusive and starts scissoring and causing rotational deformities, then you may want to plan some sort of osteotomy. But this sort of thing really needs to be treated at a tertiary pediatric centre with high volume and high experience. So well done. I don't expect many people to get that, but yeah, that's quite a common thing you might see in clinics. So that's a good thing to spot. So with wrist pain, you can divide into kind of central wrist pain, radial sided wrist pain, and ulnar sided wrist pain. And there are lots of different things that can cause this sort of distribution of pain. But I'll touch upon the really important things and really the bread and butter of hand surgery, what you'll see in all of your clinics. So we'll cover basal thumb arthritis, we'll cover de Quervain's tenosynovitis, and also scaphoid non-union. So basal thumb arthritis is an extremely common condition. It usually affects postmenopausal women, and it doesn't really have a hand dominance, but it can affect the dominant hand more than the non-dominant hand. And really what we think is that the thumb undergoes an extreme amount of joint reaction force, especially when gripping things and pinching things. It can be up to 10 to 13 times increasing your joint reaction force when you grip something at that CMC joint. It's a biconcave saddle joint, which gives you fantastic range of motion. So it's a highly specialized joint that does a lot of work day to day. And what we think is that you've got a number of pathophysiological events that cause the arthritis of the base of the thumb. So what people think is that there's an attenuation of something called a volar beak ligament, which is at the front of the thumb. Is deep within that, and that connects the thumb metacarpal to the index finger metacarpal. There's also the dorsal oblique ligament, which is also a very strong ligament on the back of the CMCJ of the thumb, which also can be implicated in this disease. And so when that beak ligament becomes worn or attenuated or stretched, it causes subtle instability of this CMC joint. And every time you stress it or pinch or grip things, that joint reaction force increases, and this can cause arthritis in that joint. So what happens then is that the thumb metacarpal becomes adducted, and then in a compensatory action, the MCP joint can then hyperextend because they're just trying to keep their thumb functional. You also get squaring of the thumb on clinical examination. It's also important to examine the neurological status of these patients, because up to 50% of them can have concomitant carpal tunnel syndrome, and they generally go hand in hand. So it's often important to look into that a little bit more detail. So they come to your clinic, you're going to take some specialized views. So you've got a PA radiograph that I've demonstrated there, which shows quite good going arthritis. On the right side, you've got something called a Roberts view, where the forearm is pronated, and then you get a view right down into the CMC joint, and that's quite a nice view to get an exact understanding of the distribution of arthritis. It was classified by Eaton and Littler. I don't think it's a very helpful diagnosis, because helpful classification, as I think that there's a broad spectrum of how the patient presents and what the radiographs look like. So often you meet people who've got very severe pain, but they don't really have much by way of evidence of arthritis on the x-rays. So it doesn't really correlate clearly with that. And then you get patients who've got severe, almost ankylosing arthritis, who are quite comfortable and are not really bothered by it. So that's something you should be aware of in terms of a classification and people use in publications and to communicate. However, I don't think it dictates what kind of management you would offer these patients. So clinically, you would perform a grind test where you axially load the thumb, and that could be quite uncomfortable, so just be very careful about that. So that's base of thumb arthritis. There's lots of different treatments for base of thumb arthritis depending on the patient that you're dealing with and the activities and hobbies. So it's all important to take a thorough history about what their aims of their treatment is. Generally, analgesics and NSAIDs are useful. Refer to them to hand therapy, and they can certainly retrain some of the muscles around the thumb to try and reduce some of those joint reaction forces. And they may supplement this with something like a splint. So this is called a push-up splint. So that gives you better pressure on the volar aspect of the thumb to try and stabilize the CMCJ. They may want to modify their activities, and quite often judicious corticosteroid injections into the joint can also be helpful in settling their symptoms down. You need to explain to them that steroid injections could be quite useful. However, they do decrease in their efficacy the more times you use them. So that's really the kind of non-operative collection of treatments that you might want to offer someone with CMCJ arthritis. So you then meet someone who's exhausted all those things and are really desperate for an operation. Now, this opens a whole can of different treatments which are tailored to different types of people. If you've got arthritis with a particular distribution, especially volarly, you can offer them something called a metacarpal osteotomy. So what that does, it realigns the metacarpal so that not so much joint reaction force goes to the volar arthritic part of it, and then redistributes the load dorsally so that they bear weight and articulate on cartilage, which is in good condition. In young active labourers, you might want to offer them something called a CMCJ arthrodesis. So that's the middle picture. That's where you fuse the bones together to make it into one block. But you must, and that is actually relatively well tolerated because you've got quite good compensation for the MCPJ and IPJ. But you also will definitely lose some range of motion there. That's something that should be offered to kind of younger people who are labourers and who just want to go back to work as soon as possible with also debilitating arthritis. There are things and clever operations such as CMC denervation. So there's specific nerve branches that come to the carpal metacarpal joint, and you can divide these surgically and selectively, which doesn't give you any other neurological deficits, but then essentially disconnects the joint pain from the brain, so that can give you some good pain relief, and it's actually quite good evidence that that can be helpful in this context. The mainstay of treatment really is something called a trapeziectomy, or a trapeziumectomy. So we surgically remove the trapezium, and then there's something called LRTI. So there's a school of thought that if you remove the trapezium, then the metacarpal can collapse into that gap, which you can see here, and it leaves a space. Now, there's lots of studies to say that you should leave the space alone, or you can use bits of tendon such as a FCR or APL, put them into a ball, and also suspend the metacarpal so it stops it collapsing down. And there's quite a few studies done by an author called Tim Davis, who says actually there's no real difference between just doing a simple trapeziectomy versus doing these other supplemental procedures. So you might hear about trapeziumectomy and also additional procedures, but the evidence doesn't show that just doing a simple trapeziectomy is an effective procedure for this. And then really coming into the kind of up-to-date treatments for this is CMCJ arthroplasty. So it's almost using technology that's used in hip replacements for many years, and essentially putting a little socket in the trapezium and then a stem with a head in the metacarpal, and that gives you a brand new articulation, just like a replacement. So that's been used for some time now, and there's some good data that in the right patient selection, that can be a very effective treatment for people. So essentially there's lots of different options for these. It's dependent on the surgeon availability, the skill, and also what kind of treatment the patient would like, and the outcomes. So think about all these different options when you see someone with basal thumb arthritis. We then move on to decurving. So it's a very common condition, and it's really a condition which involves the first ortho compartment of the wrist. So that includes APL and EPB, and it's a very commonly seen thing. The classic presentation is a female who's of childbearing age, who's had a newborn, and they get repeated ulnar deviation of the wrist because they're lifting the child up repetitively, and that causes inflammation of the first ortho compartment. So it's very common, and there's different tests that you can do. There's something called Finkelstein's maneuver. So Finkelstein's is actually where you pull on the thumb and then rapidly ulnar deviate the wrist, and that recreates discomfort on the radial side of the wrist. Eickhoff's maneuver is where you put the thumb under the palm and then also forcibly ulnar deviate, and then take the thumb out of that deviated position, and that then relieves their pressure. So often people get that mixed up and call that second test Finkelstein's, but actually it's not. The mainstay of treatment,
this one,
anti-inflammatories, splinting, and then steroid injections, and the surgical treatment for this is surgical decompression. You've got to be aware that the first ortho compartment, especially the APL, has multiple slips. So when you do decompress these, you should be aware that you may need to decompress multiple compartments of the APL, and you don't want to miss these because that might cause continuing symptoms. So that's really decurvings. So spotter number 2, you get a 50-year-old lady who comes to your clinic with this swelling of the finger. What do you think it is? What do people think it is? Yeah, great. It's a classic DIPJ with mucoid cyst, and I'm really pleased that nobody said it was a wart. So a mucoid cyst is essentially a little ganglion of the DIPJ, and really what it's caused by is an underlying arthritis of the distal inferior joint. And classically, what you get is a spicular bone, which then protrudes and then causes a weakness in the capsule and allows some of the synovial fluid to leak out, usually to one side of the extensor tendon. So it's a very common condition. In terms of treatment, most of these can be managed non-operatively. If they're causing symptoms such as leaking kind of serous fluid or synovial fluid, or if they're infected, then they can be excised, but it should be very, noted that that spicular bone needs to be removed in its entirety, as it can have quite a high recurrence rate. So it's a very common condition. If you see it, get an X-ray and then counsel about the various treatment options. Scaphoid non-unions, I'm going to really, this is an absolutely massive topic, and I think Dan's touched upon it in his talk. There's another common cause of radial-sided wrist pain. They may have had some sort of antecedent injury many years ago which wasn't treated, and they'll present with this sort of picture where you've got a clear non-union of the scaphoid. You can see on the MRI scan that the proximal pole is presented with low signal, which suggests that the vascularity of the proximal pole is compromised. There's different ways of managing these patients. So simple things like cessation of smoking. If they've not had an inadequate amount of immobilization in their cast, then that's something that you might do just in the acute phase. But generally, these patients need to be counselled about whether they need operative intervention. So what that would involve is an open procedure usually, and depending on the location of the bone, the defect and the non-union, they may require open reduction internal fixation with some sort of bone grafting. And you can see here in the middle image, they've taken a little beautiful cortical window of distal radius and then plugged it into the non-union site and supplemented with a screw which has compressed the bone together. There are lots of different options for this. People are using vascularized bone grafts, so they take a little pedicle of with artery and vein and plugging into the defect, and then some people using non-vascularized bone from other locations. So that's probably beyond the remit of this. But if you see someone with a scaphoid non-union, then you should be really getting adequate X-rays and probably CT scans, and then referring them and escalating to your consultant for further management. So what happens if you don't treat scaphoids? You develop something called scaphoid non-union advanced collapse. It's something called a snack wrist, and there's a progressive arthritis of the wrist, and you get generally something called there's 3 or 4 different stages. In the initial stage, you get radio scaphoid arthritis. So there's on the radial side you get joint space narrowing, and then this progresses to scaphoid capitate arthritis, and then pancarpal arthritis, and that's something that you might see somebody presenting with stiffness and pain in the wrist, and that's how they might present. What do you think this is? Somebody presents with a funny looking nail. Are you worried? Not worried? Yeah, great. This is a worrying appearance. It's something which you should really be thinking about when it comes to the hand. So we love to look at, as an orthopedic perspective, we love to look at joints and things like that, but also be aware that you'll be presented with things like skin cancers and other nail problems as well. So if you see something like this, it's likely to be it could be a subungual melanoma, and this really needs to be referred to a dermatologist urgently to go through an MDT. So that's something you should be definitely aware of, is that don't just ignore the skin. If somebody presents with a lump, it might be some sort of cutaneous carcinoma, which in this case a melanoma can be malignant and cause other problems. So well done for spotting that. We go into central wrist pain. I'll touch upon 2 subjects. There are lots of other diagnoses, but these are quite interesting things which you might see. Kind-box disease, so that's a condition where there's an avascular necrosis of the lunate, so that's the bone within the proximal row of the wrist. What it is that they often have centralized wrist pain, and we don't really know why it's caused, but we know there's a few different things which can contribute to it. So some patients have a very particular type of blood supply to the lunate. So there's things like an eye-shaped blood supply which can cause it to give you a slightly higher risk of that. Some patients have a vague history of trauma many years ago which can trigger it. And then some people have slightly altered biomechanics of the wrist. So things like a negative ulnar variance, where the ulnar is shorter than the radius, can increase pressure on the lunate, which can precipitate Kienbock's, and also decrease radial inclination. It was then, so you might see someone like that, they might be quite young, so you get different stages. So Lichtman described stages of it, and it's various X-ray and MRI appearances, and then also goes on to the kind of arthritic progression of the condition. There are lots and lots of different treatments for this. The mainstay of treatment is splinting and NSAIDs to try and control the symptoms, and depending on what stage the condition is, so things like Lichtman stage 1 and 2, where there's not much collapse of the bone and the lunate's in a reasonable shape. The aims of it are to try and restore blood supply to the lunate and decrease the pressure. So what you can do is you can do something called joint leveling procedure. We can try and level up the radius and ulnar to decrease the pressure. You can decompress the distal radius by drilling it, and that increases the blood, supposedly increases the blood supply to the lunate. And then you can also do operations where you can plug new bits of bone in with vascularized bone grafting. And then when the patient unfortunately develops arthritis, you can go on to other salvage procedures such as proximal carpectomy. So that's where you remove the proximal row of the carpus, and fusions and arthroplasty. So something that is relatively rare, this condition, but when you see it, it's quite classical in its appearance and something you should be kind of aware of. Wrist osteoarthritis is a huge topic in itself. It can be primary or secondary, so secondary to your scaphoid non-unions that we just talked about, or scapholunate advanced collapse, which is where the scapholunate ligament's been ruptured and there's developed arthritis because it's not been treated. Once again, it's similar to Kienbock's. You really need to manage the symptoms and then reserve your operative interventions for when there is an appropriate time. Ulnar-sided wrist pain is a really interesting topic. You can see in this sketch diagram that there's lots of structures there. The key structures I really wanted to draw your attention to are things like the TFCC, which is the triangular fibrocartilage complex, which sits just above the ulnar head and articulates with the proximal row of the carpus, and then also is also a crucial part of the distal radial ulnar joint. Alongside that, you've got the piezotriquetral joint, which can develop conditions such as arthritis, and you've got the extensor carpi ulnaris tendon, which also forms part of the stabilizing structure of the DRUJ. So when you come to the ulnar side of the wrist, it's quite common that you see people with distal radius fractures present with ulnar-sided wrist pain, and actually it's quite a challenging area of the wrist to try and deal with because there could be multiple things going on, such as TFCC tears, arthritis, and ECU tendonitis. So I really won't go into too much into this because I think that in itself it's a big topic, but keep this diagram in your mind when you think about these patients with distal radius fractures or any other trauma that come back with discomfort on the side of the wrist, and take it seriously because there could be an underlying issue here. With these patients, the investigations of choice are really MRI scans and also arthroscopy of the wrist as well, which is we can have a direct look and probe these structures and see what's been damaged and repair as appropriate. Other things that you might, so kind of common conditions now, I'm going to just kind of skip through these a little bit. Carpal tunnel syndrome is a very common condition in the hand clinic. It's a compressive neuropathy of the median nerve, and you've got a quite tight space. You've got 9 tendons and the median nerve sitting in the carpal tunnel, and it's really enclosed by the carpal bones, the proximal distal rows, and then also the transverse carpal ligament. Patients will classically tell you that they've got pins and needles within the radial 3 digits. They're complaining of night symptoms of pins and needles that's quite intrusive and cause them to wake up. And they may have other associated things such as have other conditions such as hypothyroidism or pregnancy or working manual labor. But the most common cause of this is actually a genetic or inherited preponderance to developing carpal tunnel syndrome. When you examine these patients, They may have wasting of the thin eminence and weakness of APB on examination and reduced sensation. There's a few different provocative tests that you can perform, such as Tinel's, Phelan's, and Durkin's, and these really give you an idea that the nerve is not very happy in this. So you may consider doing nerve conduction and EMG studies. I think that these, if you've got a classical history with a positive Tinel's and provocative tests, I think it's appropriate to proceed with treatment for this without a nerve conduction study. However, if you see someone that's got atypical symptoms, such as numbness within the ulnar nerve distribution or any other things that think, well, this is not quite right, then I think EMG or nerve conduction studies will be very helpful in teasing out the diagnosis. Once again, treatment can be splint orientated, hand therapy, steroid injection to the carpal tunnel in the scenarios where you're not quite sure whether it's carpal tunnel or some other condition, or compression higher up in the neck or the elbow or the forearm. Then that could be quite a powerful tool in diagnosing it. So if the steroid injection is helpful in treating the symptoms, then you're pretty secure that it is carpal tunnel syndrome. In terms of surgical treatment, those refractory to those non-operative measures would benefit from carpal tunnel decompression, and I'm sure a lot of the audience have done some of these in their practice. Trigger finger, that's where you've got clicking of the finger and catching of the digit. Is a stenosing tenosynovitis of the A1 pulley. Sometimes you can feel a nodule within the tendon, and this can catch. Green classified these according to 4 stages as shown, and treatment of it is generally symptom management or an A1 pulley release. So trigger fingers you will definitely see in your clinic, and you should really have an algorithm about how you might manage these patients. What do you think this is? Brilliant. Yeah, they're Garrett's pads. So these are associated with Dupuytren's disease. So Dupuytren's disease is a benign condition that you'll definitely see in your hand clinic day to day. It's benign proliferation of the palmar fascia, and it's described by Guillaume Dupuytren in a Lancet paper in the early 1800s, and it's really caused by the myofibroblast, which is the key cell to be aware of in this condition. It causes hyperproduction of type 3 collagen, and it causes these classical contractures that you see in this diagram. So you can see in this picture that the patient's got a flexion contracture of the MCPJ. You can see a classic cord formation within the palm, and you can see that it's very tight and he's unable to extend his finger. You can also see that the disease kind of doesn't really affect the radial side of his hand, and there's no other kind of, you can see that they've also not had any kind of operative intervention. So when you look at these fingers, just try and describe where you think the cord is and what contracture it's causing. So in your normal palm, you've got these structures and the fascia within the structure, and there's really proliferation of these normal structures which causes these joint contractures. So you've got your Grayson's ligament, your Cleland's ligament, which are enclosed neurovascular bundles in the finger. You've got pretendinous bands, and when these become pathological, they turn into pretendinous cords. As they go into the finger, they can infiltrate the natatory ligaments, which would go between the web spaces and cause contractures within the web spaces. And then as they go into the fingers, they can cause spiral bands. And the key thing about these things is that they can cause displacement of key structures into abnormal positions. So it's something that you should be aware of. And as these progress, they can cause contracture of the MP joint, the PIP and DIP joint. You can see here, this is an operative dissection of a little finger, and you can see in the forceps, you've got this thickened cord-like structure, which is the Dupuytren's disease. And you can see underneath here that you've got flexor tendon running, and you've also got your neurovascular bundles as well. So all the critical clockwork in the finger is very nearby these cores, and you should be very careful when you're planning procedures for these things. So what to do for these patients? There's always an option of not doing anything. This is Bill Nye. You can see in this picture that he's got quite severe 90-degree contractures of his MCP and PIP joint, but he doesn't want anything to be done about it. He's quite openly talked about this and says that actually doesn't affect his activities of daily living at all. So there is a role for that, and always talk to your patients about treatment for this. There are other treatments out there, so something called collagenase injections. So this is where you inject the cord with a collagenase injection. You then come back a few days later, and then you almost manipulate the finger into a straighter position. This causes like a carrot stick snap of the finger and causes correction of the contractures. The French have popularized something called needle aponeurotomy. So we use a fine needle with a bit of local anesthetic, and you puncture the cords and use it almost as a small blade and divide those in various places to try and straighten the fingers. You must also really explain to the patient that this is a condition which will come back. So it's really about managing expectations with this, so that you get some degree of correction of the contracture, but there's a high rate of recurrence, and you may not get a full correction of deformity. Then we go into the more invasive treatments for Dupuytrens. You've got something called segmental fasciectomies or limited fasciectomies. Can be done by various approaches. So you've got the classic Brunn incision on the ring finger described here. On the little finger, you've got something called Z-plasties, where you've got a deficiency in skin, and then you can cleverly shift around skin to give you length and allow the correction of the deformity. And then also something called Makash's open palm technique. So the beauty of the palm is if you leave little defects in the palm open, and they will granulate and they'll heal over with new skin. So it's not mandatory to cover all of the palm with skin. We're almost there. This is the last spotter, I think. What do you guys think this is? Brilliant, yeah, classic ganglion cyst. So ganglion cyst is really an extension of the mucoid cyst. It's a weakening of the essentially ligaments or the joint capsule. This causes synovial fluid to leak out, and you can see here that you've got a cyst-like structure on this dissection, and you've got a stalk which connects it to the in this case a scapholunate ligament at the back here. It's a very common condition. Lots of different treatments where you can leave them alone. People classically describe hitting them with a Bible or aspirating, but these have high recurrence rates. So generally, if they're not symptomatic, they should be well left alone. And then finally, a very interesting topic, and something that is probably seen less and less now in hand clinic because of the advent of excellent DMARDs and anti-TNF alpha and monoclonal antibodies by rheumatologists, but you may still see a cohort of patients who've got quite severe deformities related to rheumatoid arthritis. So rheumatoid arthritis is a inflammatory condition of the joints of the hand and also all the joints in your body. They are classified. They are characterized by IgM binding to IgG, and then creating something called rheumatoid factor, which causes synovitis and destruction of joints. So you can see in this picture on the left, this lady's got kind of a Z-type deformity of the hand. The wrist is only subluxed, which is then cause a metacarpals to radially deviate, and then malalignment of the MCPJs. So it looks quite an alarming picture, and also X-ray appearances. And really, there's lots of different treatments for these, and it should be tailored to the patient you're dealing with. Often these patients function extremely well, and therefore they don't require any kind of operative intervention or any treatment. They can manage quite well with splints. Generally, the principles around rheumatoid surgery is to do procedures which are highly effective. So they may have carpal tunnel syndrome, so decompressing the carpal tunnel is an effective thing, and then also working proximally to distally. In this case, this patient may be troubled by extensor tendon ruptures or the malalignment with MCPJs, and you may want to offer them things like joint replacements and silastic replacements and tendon realignment surgery. So there's lots of different options with this, and it's something that you will see in clinic, but it really is a patient that will be with you for many years, and you'll look after their hands for them. So that's really a super whistle-stop tour of hand surgery. I don't think I've done any of the topics justice, and we could talk about them for hours, but I think it gives you a flavour of what hand surgery entails. And I'd like to invite any questions if anyone's got any.
Thank you very much, Mr. Vaghela. Don't think we have any questions yet, but thank you very much. And I'm just going to stop sharing your screen, and thank you very much for everyone for joining us for our very last session of the Fundamentals of Orthopaedics series. We will be doing more ST3 related stuff in a month or two's time, so do look out for that.